conclude our discussion on cost, quality, and access in health services in this module, focusing in on the quality aspect of health services. Now, when we talk about quality in health, we need to start thinking in terms of medical errors. At the beginning of the semester, we started talking about an important report that came out from the Institute of Medicine called To Err is Human. If you remember back, To Err is Human was really a groundbreaking report that shifted the paradigm on the way we think about medical errors and the way we think about quality in healthcare services. So this report, published in 1999 by the Institute of Medicine, and really worked to bring increased awareness to medical errors in the United States and really bring it to the forefront of national concern and really create this national urgent need to start looking into medical errors. Now, when we look at medical errors as a cause of death, we can quickly start to see why we consider it a real public health emergency. Medical errors are the third leading cause of death in America. There's an estimate between 98,000 to upwards of 400,000 people a year are dying from medical errors. Now, this makes it, like I said, the third leading cause of death in America, and this is behind diseases like heart disease, which is first, and then cancer, which is second. So even if we take that low range of 98,000, that still makes medical errors the sixth leading cause of death in the United States, and that higher estimate of 400,000 makes it the third leading cause of death. But it's really hard for us to put an exact number to the amount of deaths that can be attributed to medical errors, because not every error is reported. The Journal of Patient Safety has even come out to say that these numbers may be higher than what has previously been reported, and they are estimating that the actual numbers could be between 210,000 and 440,000 patients each year who are going to the hospital for care and suffering some type of preventable harm that contributes to their death. So when we think about it, medical errors and the deaths that we are seeing, unlike heart disease or cancer, these are deaths that should not have occurred but did occur due to some type of break in quality or some type of medical error. Now, not all of these are at the fault of the clinician or the clinic or the hospital or the provider, but are also due in part to patient compliance issues as well. And most often than not, what we see that is that most errors in health services are systematic, meaning that they span the entire system. There was a breakdown somewhere along the system that was almost a domino effect into other areas, not just on the individual provider level. So let's quickly put that in a little bit of relatable terms to really emphasize how large of an issue medical errors and deaths that occur from medical errors really is, and how large this issue can become. So I want you to remember this figure: 3, 4, 747, 250K. Now, what does that mean, and why do you need to remember that, and how does it relate back to medical errors? Well, 3, that's the number 3 cause of death across the United States. That equates, if you put that in relatable terms, to 4 747 airplanes falling out of the sky every day of the year, and estimating about 250,000 deaths if we take that mid-range number. So that's 250,000 people at the mid-range unnecessarily dying every year due to a medical error. Again, that's like 4 747 planes falling out of the sky every day for a year, making medical errors the number 3 cause of death across the United States. So now that we can understand a little bit more about why quality and medical errors are such a huge public health concern and a health concern for the health industry itself, let's talk about quality in regards to patient safety, averages, and initiatives. And first, we're going to discuss patient safety issues. So there's a few reasons that contribute to medical errors overall when we start to categorize them. The first one is that our healthcare system, we operate in a decentralized system. So remember back when we were talking about how the hospital, or the healthcare system rather, is structured, we're very decentralized and very fragmented as a healthcare system overall. So how does this lead to medical errors and issues in quality? Well, because we are so fragmented, because we are so decentralized, we have too many what's called handoffs of information. Think back to the telephone game that you would play when you were younger. The message would start one way with the first recipient, and by the time it got to the very end, it was a completely different message. It's the same kind of thought here. We have too much room and too much opportunity for error with all of the communication and the information handoffs that exist because of the way that our system is designed and structured. The second reason, and as we've covered before, our healthcare system overall at this point in time remains very geared towards acute and episodic care. We don't necessarily focus on preventive care. We kind of take care of things as they come up. So we're very reactive. We just focus more on the episode of care instead of the whole continuum of care. Also, as we've discussed before, just the science and the technology that go into healthcare itself is moving at unprecedented rates. Healthcare technology and the science and best practices and research that we're doing in healthcare, we learn something new every day, or something changes, or something's advanced almost every day in healthcare. So it can be very difficult to translate that knowledge that we're learning into practice, and it's really difficult to try and integrate technology safely and appropriately, because remember, the consumer wants the latest and greatest and newest and best, and so do hospital and healthcare systems. But now we have to learn how to integrate that technology safely into the care of our patients. So because we are moving so quickly, it's almost as if the healthcare system cannot keep pace with the rate that technology and the knowledge that we're gaining is changing. The fourth reason or the fourth contributing factor rather to medical errors is that healthcare itself is just growing more complex. So feeding back into what we just talked about with technology, even back into our decentralized and fragmented system, healthcare itself just growing so much more complex. There's so much more to know. There's so much more to do, not just with patient care, but new regulations that are coming out from the government, things that healthcare systems have to comply with. Those regulations change almost daily, just like technology. So there's so many more facets that we need to know that almost go beyond just clinical care of our patients. And there's so much more to do, particularly in this current setting. Our clinicians and our practitioners and our providers are constantly being asked to do more with less, provide more care, better care with less resources overall. So that can lead to a couple reasons that we're seeing medical errors. And the fifth and final reason that contributes to medical errors from what we see are that public health care needs are just changing. We've often talked about through this class how our demographics in this country are shifting. So we're seeing more of a retirement population coming up. But think about it just in the long term. Outside demographics, people in general are just living longer, which is great. That's great for us, but what comes with that? That comes with more chronic conditions, more comorbidities, more illnesses, more long-term conditions that we have to figure out how to work and how to manage. So, but because our healthcare needs in general are changing, we are living longer, but that's constituting more advanced care that we're needing for the various illnesses that we're starting to experience. But looking at all these contributing factors, think about how this affects the patient. So these medical errors really work to exact significant tolls on our patient population itself. And there's three main areas or three main categories that we can define here in terms of these significant tolls that we're seeing that are exacted on our patients. The first one of those is the human toll. This is simply just loss of life and functioning. Remember, medical errors count for, at the high end, the third leading cause of death in the United States behind heart disease and cancer. And unlike those diseases, these are deaths that should have never occurred, but did because of some breakdown in the system, some error that occurred. So the first toll is that human toll. Then think about the economic toll. We spend at last estimates upwards of $29 billion when you account all the factors due to medical errors, and I'm sure that figure has surpassed even those last estimates now. What's factored into this is loss of income, expense of additional care that we would not have otherwise had to receive because of these medical errors, disabilities. You know, we may experience a medical error that puts us out of work for the rest of our life, so that's lost income. And we're not able to work. Now we have to be on disability services. We may qualify for Medicaid now because we're disabled. So think about the feed-down effect, not just human toll, but the economic toll and the domino effect that medical errors can have economically. And the last toll, probably the most easiest to lose and the hardest to gain back is trust. You as a patient may lose trust and confidence in the healthcare system. You may lose trust and confidence in the patient-provider and relationship. There may be decreased satisfaction, and we all know once you lose that trust piece, that confidence piece, it's very hard to gain that back. So three tolls that we particularly look at in concerns to medical errors and the effects that medical errors have are the human toll, where we look at loss of life, the economic toll, where we look at things like lost income, disability, and most importantly, the trust piece, because once we lose that trust, it's very hard to gain that back. Now, when we look at averages and quality, there's three main domains that we want to focus in on, and that's going to be our structures, our processes, and our outcomes. Now, what we want to remember before we get into these three domains is the overarching goal of quality in healthcare, and the one thing that we need to remember as practitioners is that our patients or our customers overall want care that is steep. We've covered STEEP before, but just as a recap, STEEP is an acronym that stands for safe, timely, effective, equitable, efficient, and patient-centered care. As a patient or as a customer, we all want care that meet that STEEP criteria. Now, we find that STEEP criteria contained within the three domains that we're going to focus in on. So when we look at structure, we're looking at really our resource inputs. So our facilities, do we have accreditation? Do we have licensing? What are our staffing levels? Do we have the appropriate equipment? So anything that involves the structure of our health system or our health facility itself. Now, when we look at process, we're looking at the actual delivery of care that is given. So we're taking it from a technical perspective, looking at diagnosis and treatment, waiting time, cost, and these are all aspects that are you can compare on different government sites like hospitalcompare.com, but we're also looking at the interpersonal aspects of care. So are our patients treated with dignity and respect? Are all their questions answered? Are all their concerns answered? What's the level of communication between your healthcare team and the patient? Or just looking at the healthcare team itself, how well are they communicating between disciplines? And the third domain that we're going to focus in on is our outcomes domain. So here we're looking more at the final results. What was our patient satisfaction like? Did we see improvement in our patients? Did they recover in a timely manner? If we're looking at the community as a whole, what is their health status? Have they seen an improved health status as the result of different programs and initiatives we're doing? So those three domains, structure, process, and outcomes, we can find that STEEP model embedded in each one of those domains. And remember, STEEP meaning safe, timely, effective, equitable, efficient, and patient-centered care. Now that we understand the three domains that exist in quality for health services, let's take a look at the two perspectives in which we can look at quality. So we can take a micro perspective and we can take a macro perspective. So in the micro perspective, we're looking at issues and items that deal with the point of delivery of healthcare services. So these are going to encompass things like medical errors themselves. We're looking at quality of life, health outcomes, patient satisfaction. So really we're looking at the performance of the individual or the organization. We're keeping a very micro perspective on things. Now when we take the macro perspective, we're looking at quality from more of a population standpoint. So we're starting to reflect on the performance of our entire healthcare delivery system from one end to the other. We're looking at all aspects including cost, access, and population health. So we've talked about medical errors and quality issues that we've seen. We've talked about safety, patient safety concerns and averages and different ways we can look at quality. But let's talk about what we're actually doing to try and get rid of medical errors and try and improve quality in healthcare in general. So let's go back and spend just a little bit more time on that acronym that we visited before when we talked about the domains, and that was STEEP. STEEP, we'll take this one letter at a time, but remember the overarching goal is that patients want care that is going to be safe, timely, effective, efficient, equitable, and personalized or patient-centered. So in SAFE, in that category, what we're looking at is we're working to avoid injuries to patients. Nobody wants to come into our healthcare system and be injured as a result of being in the healthcare system. So we're here looking to avoid injuries to our patients. Timely, we're looking to reduce wait times overall. Go back to what we mean by access to healthcare. We want healthcare that we can receive in a timely manner. So in timely, in this acronym of STEEP, what we're looking at is the reduction in wait times and delays between cares. So we may get back to see a doc, we may get back into the emergency room, but how long do we have to sit in that hospital bed before we actually see the nurse or the physician or the provider or the clinician? So not only are we looking to reduce wait times, we're looking to reduce delays in care for both those who receive and those who give care. So it's not just on the patient side, but there may be issues set up in our processes on the clinician side that prevent them from giving timely care. They may have to wait to bring that patient to x-ray because they're backlogged with other patients that they have to x-ray, or the orders aren't written out correctly, or the system crashes. So it's not just on the patient side, but on the clinician side as well. Now, when we talk about effective care, we're talking about providing health care and services to our patients that's based on that scientific knowledge. But go back to, one of the issues that we're having in terms of the contributing factors we're seeing to medical errors is that science and technology are just moving at these unprecedented rates. So it's very hard with us to continually try to keep up. We're almost being outpaced by the way technology and scientific knowledge is moving. But in effective care, we need to strive and do our best to provide services that are based on the most up-to-date scientific knowledge. And when we look at efficient, it's just what it means. How can we provide the most efficient care that takes care of the safety piece, the timely piece, the equitable piece, through avoiding waste that's built into our system? How many unnecessary processes do we have out there that we don't need to complete, or how many unnecessary steps do we go through just because that's what we've always done? So how do we work to kind of move those out and still offer safe and timely care that's now more efficient for our patients? When we look into equitable care, going back to our access piece, how can we start to provide care that doesn't really vary in quality because of different personal characteristics? So how can we make sure there's equitable and access to care for our patients? And then personalized care, or you may hear this called patient-centered care. And again, just like efficient, this is exactly what it sounds like. How do we provide care that's respectful to our patients and responsive to individual patient preferences, needs, values? How do we take that cultural competency piece and integrate that into this personalized and patient-centered care? We know not all cultures, all religions, all races, all minorities value the same things in their healthcare. So how can we take this patient-centered piece and really start to integrate cultural competency here? So to further expand on our quality improvement initiatives, we'll face facts and know that almost everything we do, if we want results, it's tied to money and it's tied to finances. So one huge initiative that has really changed the way we are delivering healthcare and starting to work to improve quality and cut medical errors that we're seeing and quality issues that we're seeing is something called our value-based purchasing program. And we covered this briefly in financing, so we'll go over a couple different aspects that I want to point out with value-based purchasing. There's three main components to the value-based purchasing program. The first one of those are hospital readmission reductions. So under value-based purchasing, if you have a patient that's discharged and readmitted to your hospital within 30 days, you either as a hospital receive no reimbursement payment or a reduction in the payment that you would normally receive for that patient. Because if that patient is readmitted back into your facility within 30 days, the thought is that they didn't get the quality of care or the needed care or the expected care that they needed while they were in the hospital to help them heal, to help them recover, and keep them out of the hospital. So if they're back, it's likely due to some complication or some breakdown in the care that they didn't receive while they were in your hospital. Now, the important thing to remember here too is this is not all on the clinician. Patient compliance is a huge factor here. So if we have patients that aren't taking their medications, we have patients that aren't sticking to their prescribed care plan, that can really complicate things with our 30-day readmissions. The next component under value-based purchasing is the hospital value-based purchasing program itself. Now, if you'll remember back to finance when we talked about value-based purchasing is a way that hospitals are being reimbursed now on the quality of care they are giving to their patients and their improvement metrics amongst their patient population. So now we're no longer being reimbursed on fee for service. Now we're starting to be reimbursed, and we're starting to see this shift towards reimbursement based on quality. So there's two metrics that we look at under value-based purchasing program, and that's clinical metrics and patient experience metrics. And it has about a 70-30 split, with 70% clinical, 30% patient experience. Now there's 13 measures that we look under clinical. And you can visit hospitalcompare.com and learn more about those metrics, or those 13 different measures. But a couple different aspects that we're looking at are things like timely and effective care, how we're measuring complications, deaths, unplanned hospital visits, things like medical imaging, and payment and value of care in general. Now, under the patient experience piece, many of you may have heard the term called HCAHPS, or some people still call it Press Ganey, but this is the Hospital Consumer Assessment of Healthcare Providers and Systems. So these are your patient satisfaction scores, and it covers a wide array of areas for the patient to really think about their care while they were in your facility. So how was the communication piece? How was the delivery of care? It even gets into things like, how was your food while you were in the hospital? So there's a lot of different aspects that we look at here, but under the value-based purchasing program, again, we look at two main aspects on how we're reimbursed, and that's clinical indicators, so overall and in general, the quality of care that we are giving to our patients and they are receiving, and then the patient experience piece going off those patient satisfaction scores. Now, I do want to note here with the patient satisfaction scores, this one can be a little tricky because generally there's a low return rate on those patient satisfaction scores. And who do you generally hear most from, or who has the loudest voice? It's those customers or those patients that had a really bad experience. So you may have had 100 patients that had really great experiences at your hospital, but don't fill out the patient satisfaction scores, and you have a handful of patients that may have had a less than desirable experience at your hospital. Those are typically going to be the ones that fill out those patient satisfaction scores. So this metric, in my opinion, takes a little bit more looking into, a little bit more investigating, because you can't take everything for face value. You may have had, like I said, 100 patients out there that had really great experiences, and you may have had a handful of patients that just had a less than desirable experience, but those are going to be the ones that speak out. Now, the third item that we'll look at under value-based purchasing and how we are reimbursed as a system is hospital-acquired condition reduction programs. And simply what this is if we have a lot of hospital-acquired infections, or HAIs, we receive a reduced payment in our reimbursement for the lower performing hospitals. So those that have a lot of HAIs, a lot of hospital-acquired infections, are going to be receiving a reduction in reimbursement payment from insurance providers and from the government in terms of Medicare and Medicaid reimbursements. So just to recap for quality, quality is becoming a huge public health emergency almost. I wouldn't even say an issue anymore, but now it's at the levels of where it's an emergency. Remember back, it's the third leading cause of death, and why this is so astonishing and so concerning are these are deaths that should have never occurred but did because of some medical error that occurred within the system, whether that was on the clinician side or whether that was a patient compliance issue. So third leading cause of death behind heart disease, behind cancer, and just becoming a huge public health emergency. Now remember those 5 factors that contribute to medical errors overall and what we can contribute to medical errors. Things like our decentralized system, how we treat more episodic care, how fast our technology is advancing, and how complex we are growing as a healthcare system, and the changing needs that come with that. The 3 tolls that we see that can be shaken because of medical errors in terms of our loss of life and functioning, our loss of income and disability, and trust between the patient and provider overall. The different perspectives that we can look at for quality. So we have that micro perspective where we're looking at the point of delivery, and that macro perspective where we're taking the population perspective standpoint, and the 3 domains that feed into that in terms of structure, process, and outcome. And a couple of the quality initiatives that we've discussed. So remembering that customers and patients want care that falls into that STEEP criteria, and how CMS and Medicare have stepped in to implement this value-based purchasing program where we're now reimbursed on quality of care, and we have 3 different aspects that we're looking at, from readmission reductions, our value-based purchasing program itself, where we have that breakdown between reimbursement on clinical measures, those 13 measures we're looking at, and the 30% based on patient experience and patient satisfaction scores, and then the hospital-acquired infections where we receive reduced reimbursement. So overall, quality medical errors in healthcare, you can't overstate how important this is and why it has become a national focus for our communities and for our population.